Excited and honored to present this award first to Dr. Karen Winey. She is the professor and department chair, Townbrook Foundation faculty fellow in the Department of Materials Science and Engineering, Chemical and Biomolecular Engineering. Her current interests include polymer nanocomposites and ion-containing polymers, and I did ask her to please tell me what that means in lay terms. Basically, Dr. Winey, she studies the fundamental properties of plastic, which we need new and better materials for energy storage and energy conversion. We're all looking to find better ways to do that, as well as use these polymers for infrastructure. And she couples these experimental studies with simulation and theory in collaboration, I think, with your lab and with probably multi-institutional collaborations. I won't read her entire bio, but importantly, she received her PhD from the University of Massachusetts in Amherst. She did her postdoctorate fellow at A&T Bell Labs, and I know a lot of very famous scientists came out of there. She received the Specialty Creative Award from the National Science Foundation. She's a fellow of the Materials Research Society, a very prestigious society. And most importantly, she's the chair, has been here since 1992, yay, and is currently the chair, as I said, of the Department of Materials Science and Engineering at Penn, and she's held that position since July of 2016. So it gives me great pleasure and congratulations, Dr. Winey.
Well, thank you very much. I'm a big fan of this organization. I remember meeting them shortly after I arrived at Penn and being very impressed by the Penn alums, and particularly the Penn women alums. And I really want to say that the way I treat advising is I'm really just developing alums, right? Because they spend a lot more years being alums than they do being undergraduates here at Penn. And undergraduate advising, the way it works in the School of Engineering is every undergraduate is assigned a faculty advisor, and we think faculty have a unique role in advising. Advising can be done by staff as well, but there's something additional that faculty can provide, and that's really insights about the field and talking to them about what aspects of the field they find more or less interesting, and this is really helpful, I think, in career development and personal development as well. The other thing I will say about faculty advising is it's really like arts and crafts. It's really more of an art than a science because each student is so individual. And when I talk to new faculty, this is really something I try and emphasize, that you need to listen to the undergrads and hear how they're all different. And then just ask questions about how their studies are going and where they're living and how they're getting along with their roommate. And this really just opens up these conversations, which are so useful. I just want to close by I'd like to introduce the undergrads who came with me today. Teddy Kardowski is a member of our MSc Society, and that's the undergraduate organization that took the time and energy to nominate me for this. Teddy's also very active in OSTEM, which is for LGBT plus students studying in science, technology, and engineering. And then Sarah Seeger on this side is also a member of the MSc Society. So thank you to that organization. And in the middle is my daughter. And it's a real treat to have Rebecca here on campus as my daughter because she's actually my advisor.
we could all use a nice young advisor like that, that's for sure. The second awardee recipient is Dr. Barbara Riegel. She's the Edith Clemmer Steinbright Professor of Gerontology at the University of Pennsylvania and at the School of Nursing, and she co-edits the Journal for Cardiovascular Nursing. She's a nurse scientist who's been studying cardiovascular disease. In particular, she's interested in self-care of older adults with cardiac problems. This sort of led her way to studying ways of transitioning chronically ill patients from the hospital to home, which all of us really must have some experience having a sick family member or friend who has to come, from the hospital into the home, where it really is probably the best place to be if you can manage that. She's cited widely for this work and has been, her work has been used to actually, get these programs off the ground and provide scientific evidence for the benefit of that kind of thing. The interesting comment is that Dr. Riegel teaches at all levels, and I have to say that is a gift to be able to teach to the undergraduates. They need the more, basic stuff, the practical approaches, as well as teaching at the graduate level, where you have to teach your students to think in more conceptual ways, in more theoretical ways. So to be able to bridge that gap is a real talent. And I know you're extremely sought after as a mentor, both for the pre-doctoral and postdoctoral students. So congratulations, Dr. Riegel.
Oh, thank you. This is lovely. I'd like to, Karen, you're a tough act to follow. That was really lovely, but I just want to say a couple of things about advising in the School of Nursing. And I want to thank the organization for honoring me for something that I'm actually doing for fun and that I'm really passionate about. And so to have someone appreciate it is just lovely. I wanted to say something about what advising is like in the School of Nursing. We also have a system where all of our students have faculty advisors, and they're assigned to us when they first come into the program. And I love when I first meet them. They're very, very young, of course, where typically a student will come in and call me Mrs. Riegel, and I always feel like that's my mother. And but by the time they graduate, then I go to graduation and I see this adult, and I've been with them the entire time. And that's what is so invigorating, so exciting. We have a system where we don't let go of registration hold until they actually come in every semester. And so I can just sit back and know that they will eventually make their way into my office. At which point I'm able to, again, as Karen outlined, it's really not, it's somewhat about picking classes, but it's mostly about how are you doing and what are you feeling and what's happening in your life. And I've learned over the years that when I get a course problem notice, that's usually an indicator that something, it's not just a poor test result, there's something going on in that student's life. And so I immediately write an email. I call them my little love notes, and I say, I'm going to be writing you little love notes if I get a course problem notice. And then I write my love note and pull them in and find out they're depressed, they've had a crisis in the family. I mean, there's something else going on here. And it's so wonderful to be able to have the opportunity to advise in that particular situation. So thank you for honoring me for something that I really, really enjoy.
Good afternoon, everyone, and welcome. I'm honored to introduce the first conference speaker. We're so excited to have her, Dr. Neil Epperson has the distinction of holding dual appointments in both the Department of Psychiatry and the Department of Obstetrics and Gynecology at the Perelman School of Medicine, excuse me. Which leads me to my next point, because her extensive research focuses on mood, behavior, and cognition across the female lifespan. She's internationally renowned for her research in women's mental health and has received numerous grants. Most recently, she has been awarded funding from the National Institute on Aging for her research regarding the effects of estrogen and serotonin on cognition in menopausal women. Today, she will give us insights into the gender hormone relationship in her presentation titled, "What Has Sex Got to Do with It?" And I just learned that she's in a band, which is where my mind went to music, and is a band groupie, so a big music person. Please join me in welcoming Dr. Epperson. Thank you. You have every field covered.
Where is the projector? I don't see it up here, being able to move things. While they're getting that for me, I know not everybody can see me, but I'll try and move around so that you can. It's such a pleasure to be here. I have to tell you, really honestly, when Deborah Silverman, I saw an email from the Trustees Council of Penn Women, and the email from Deborah inviting me to be here, I was ecstatic. I felt like, I've been at Penn now for 8 years, but I have really come to Penn now because I'm going to be speaking to the Trustees Council of Penn Women. And so you may say to yourself, really? I mean, the faculty even know that, about this? And the truth is that you guys, in my mind, and a number of other faculty, kind of rise to mythical proportion, and which is really an amazing thing, because it means that people listen to what you have to say, and you do have influence at the institution, and you really are doing amazing things, particularly, honoring undergraduate mentoring and supervising. Again, those are people that are on our front lines dealing with our young people. My daughter's a junior here, and I just wish she had had Karen as a mentee or as a student supervisor. So, in any case, what can you do? It's a pleasure to be here, and I'm going to talk to you about sex differences and how it affects health. So let's get started. All right, so creation of new knowledge. You have to understand that this is an important factor for everything we do here in the Academy. I don't care what side of the political spectrum you are or what your background is. Most people in the Academy believe that creation of new knowledge is important and that it takes a team approach. It takes the scientist if you're in the School of Medicine. Now, if you're in arts and sciences and literature or what have you, creation of new knowledge goes a little differently. But in the School of Medicine, we have scientists. I happen to be a physician scientist, but you can be a PhD doing research. But we also have a lot of staff members that are on the front lines doing research. It also requires people like you, the citizen scientist, as we like to refer to you as. And it means that we really have to have a highly diverse group of people that are willing to participate in research. Because the bottom line is that you want whatever discoveries we make in healthcare to pertain to you, not just to a small select group of people who agree to participate in research. So we want a highly diverse group of people from multiple backgrounds, socioeconomic status, racial and ethnic groups. And obviously, we need to have our funders as well, because research can't happen. So it really is a team approach. Now, I'm very lucky. I have to say that as a clinician scientist, I feel like I'm in a great position, and I enjoy my work because I get to have face-to-face contact with the people that we're trying to help. Most biomedical research really is about trying to make the world a better place. But I would argue that most research in the Academy is about trying to influence what happens in our world, again, for the betterment of all of us. So I get to, on an individual basis, meet with people face to face. I have the honor to hear about their struggles and what they're going through. And I can also do something pretty immediate to impact that person's quality of life. So I have a great job. I also get to create new knowledge by listening to my patients. If I have a lot of women coming to my office, and I'll give you an example. When I was back at Yale, before I came here, I know it's another institution. I probably shouldn't have said what it was, but Boo. But in any case, I used to see, I still do, but I had a lot of women coming in after going through menopause, and they were complaining about a lot of cognitive difficulties. And those cognitive difficulties weren't like dementia and things like that. It wasn't that level of cognitive difficulty, but it was enough that it was impacting their performance and their quality of life. And it really made me start to think about, well, what can we do to help these women? And so we created a study focusing on what happens at midlife. Is menopause special? And I'm going to talk a little bit about that. And what do we think is happening to create these changes in cognition? So again, I get to create knowledge. I get to be a translator. So I get to, as a clinician scientist, then I am seeing patients, but I need to know what's going on in the preclinical world. I need to know what's going on at a molecular level. I need to be able to translate what I'm seeing with my patients, because we can't be as mechanistic in clinical research as you can in basic science research. So if I can take what we learn in the clinic, go to my colleagues in basic sciences and say, can you help design a study so that we can look at this more mechanistically? Then I can take that back to the clinic, and then we can take it to the community. And as an educator, I get to educate my patients, individuals, and I also get to educate the community. And I do take that responsibility very seriously. Now, I have to tell you, I grew up in a small town in North Carolina, and you may say, what does that got to do with anything? Well, I was a Methodist minister's daughter in a very small town. And my mama told me that there were 3 things that you do not talk about in big, at a dinner party, much less a crowd of, 100, 120 people. So what are those 3 things that I'm not supposed to talk about? Politics, yeah, okay, politics. Sex! I get to stand up here and talk about sex. This is really great. The other one could be religion or money, whichever one you want. But guess what, guys? And actually, we might want to dampen the lights overhead just a little bit, because there will be, not to get you in the mood or anything, but this is not really the kind of sex I'm talking about in this talk, unfortunately. What I'm really talking about is sex as a biological variable. And basically, your sex is based upon, in most situations, your chromosomal complement. Are you an XX individual, which means that you're female? If you're an XY individual, you're male. Again, we do know that it's not binary for everyone, but based upon your chromosomes and your genitals when you were born, a doctor gave you a sex and put it on your birth certificate, okay? That is sex. That is what we're talking about. Now, some people say, can't I just call it gender? Because I don't feel comfortable saying the word sex differences in front of people at dinner, or I heard this talk from this doctor about sex differences. You might feel more comfortable calling it gender differences, but this little boy I thought this was adorable. Is he a boy because he wears blue? Or is he wear blue because he's a boy? I mean, again, what I'm getting at here is that gender really refers to primarily a sort of societal social construct and how you see yourself and what gender you see yourself as being. So again, that has a lot to do with the society that you live in as well as your life experiences. So sex differences, because I'm a psychiatrist primarily, I obviously am highlighting here sex differences in brain-related disorders. And I know you're going to hear from Frances Jensen, who's going to talk to you about adolescence and people's development. And we do know that males and females, particularly their central nervous system, develops at different rates. Different parts of the brain develop, particularly the prefrontal cortex. But in males, we have a number of disorders which are more common, as well as females. But it's not just when it comes to the brain. There are so many physical conditions that affect the human species that have sex differences, either in prevalence, how often it occurs in one sex or the other, or is impacted by their hormonal state, and we're going to talk a little bit about that. And then all the disorders in the middle, they can vary between males and females based upon life exposure, where you live in the United States, or if you live in the United States at all, how old you are. So sex, age, place, location, that you grew up, all of these things can have an impact on manifestation of medical conditions. Now we have to also think about, global health. So that's at the individual level. What disorders
actually affect us globally and cause the greatest amount of disease burden. Now, the World Health Organization has a metric for this. That metric is called the disease-adjusted life year, or the daily. Basically, it's just the years of life lost due to disability plus years of life lost in general, related to a particular disease. And basically, you can go on the World Health Organization website, and you can look at any country in the world, you can look at any region based upon socioeconomics, and you can see the disorders that rank in the top 10. So in the United States and in developed countries, what disorder causes the greatest disease burden? Cardiovascular disease is what I'm hearing. Alzheimer's is another. Anybody else? Oh, shout it out. Thank you. It's unipolar major depression. Believe it or not, it's not just in developed countries that that's number one, that's now worldwide, okay? Ischemic heart disease is number 2. Number 3 is cerebrovascular disease. 4, Alzheimer's and dementia, and 5 is alcohol use disorders. 4 out of the top 5 have to do with your brain. Isn't that remarkable? I am so glad I'm a psychiatrist. Seriously, it's a great field. You know, there's so much that we could do if we just improve behavioral health. Look at the disease burden that would go down in the world. It would be amazing. Now, I'm not trying to minimize the importance of a cancer diagnosis and living with cancer, because it is really tough when it happens to you. But we have done a remarkable job being able to attack cancer, because people have focused on it for the past 4 or 5 decades. And you know, we've made amazing advances here at Penn in cancer biology and treatment with Carl June's work and what have you, and the new FDA acceptance of a cancer-focused treatment. And so it's really an amazing thing that we've been able to do. I'd like to see, and I would challenge you, can we do the same when it comes to brain illnesses? Can we really get them off the top 10? That's what I want to see happen in the rest of my career. Okay, does sex matter here? Well, I wouldn't ask the question if I didn't know the answer. And of course it is yes, sex does matter here. Women have twice the disease burden related to unipolar major depression as men. So that's critical. Also, number 10 is Alzheimer's disease and dementia. More of a disease burden for women. It doesn't even rank in the top 10 for the men. Alcohol use disorders and lung disorders seem to be far more of a burden for males. So this is so important that the National Institutes of Health, and this is Francis Collins, who's the director of the NIH, and Janine Clayton, who's the director of the Office of Research on Women's Health, have basically created a mandate for all biomedical research that we know the sex of the cells, the tissue, the animal, or the organism that we're studying, and we justify why we would choose to study one versus the other. If you're only going to study one, you've got to have a darn good justification for it now. Because I was talking with a colleague of mine at a local institution, and he studies cancer biology, and he studies how these viruses can infect a cell and leave material in the cell that changes the cell and makes it more or less a better target for chemotherapeutic agents. And I said, well, what's the sex of your cells? And he says, we don't pay any attention to that. And I said, really? So let me challenge you here. Wouldn't it make sense that when you're doing the research in the Petri dish, that you know whether this is going to be the cell is going to look different after infection if it's a female cell or a male cell. Maybe female cells put out a protein that could be targeted better by this drug. Or maybe the male cell puts out some kind of a target for chemotherapy. Isn't it better to know now than after we've spent millions and millions of dollars and submitted people to participation in randomized clinical trials? Wouldn't it be better to know now if women and males it works just as well, or that there's no sex differences once it's infected. So again, it's really important thinking about the rigor of our research. So we undertook a study here at Penn with some undergraduate students. I am the director of Penn Promotes Research on Sex and Gender and Health, and we received funding from both the provost office as well as the deans in the School of Medicine. And the bottom line is that what we did is we looked at a bunch of protocols. People, faculty members, for those of you who don't know, we have to write up what we're going to do. And we have to justify what we're going to do and talk about safety and what have you. So we have to say how we're going to analyze the data, who we're going to recruit. And so these were mostly human subject studies that we were looking at in this first pass. We wanted to see how well our faculty here at Penn pay attention to sex and or gender of their participants and how it might impact the outcomes that they're planning to study. So we looked at these data, and we found that of the protocols that we reviewed, about 63% of them were studying topics for which the literature already tells us that there are known sex differences. Already. So we already know it's out there. It's not something that would be a surprise. Only 3% of that 63% were actually going to look in their analyses at how sex or gender impacted their outcome. So the bottom line is that we have a long way to go, and we're working on it. So how do we get I'm going to focus on the brain here because I am a psychiatrist, sexual differentiation of the brain. Well, that happens in utero, by and large. Basically, the male fetus starts to make testosterone because his testicles start to form, and he starts to make testosterone in utero. That testosterone gets then aromatized to estrogen. So the male brain is exposed to more estrogen in utero than the female brain, and that masculinizes the central nervous system. And you would say, wow, really, that's amazing. I thought it was always androgens. Well, no, it's partially androgens, but partially how androgens get converted to estrogens. So, is gender and sex binary, particularly when it comes to the brain? And how is it that we can have binary sex organs, but we all know that the brain seems to be a little bit special. I mean, people's behavior is not always consistently what we think of as male or consistently what we think of as female. So the sexual organs are destined in the first trimester. Thank you for laughing. Thank you. I cackled when I saw this online. I loved it. So thank you. Whew. So you have a fairly narrow range. I mean, yes, there are people who have genetic defects and genetic problems and what have you, so that their genitalia is not clear when they're born. But that is definitely a minority. Most people are going to be more binary when it comes to their sexual organs. But we think of now as the brain, we stop talking about dimorphic or two forms of the brain or two forms of different brain regions. We're starting to think really much more of the brain as a mosaic, where basically you've got second and third trimester exposure to different levels of hormones. And yes, you've got some females that seem very feminine and some males that are very masculine in their behaviors. I'm not even talking about how they look, but in their behaviors. But we all know females that have some aspects of their personality or how they think that seems more masculine based upon our society, and the same thing for males. So again, there's a mosaic. It's not binary. And certainly sexual preference and sexual identity is not binary, at least when it comes to how people think about themselves despite what their sex organs are. And we know particularly for women that reproductive hormones are very important. So in puberty, you start having ups and downs in your hormones. In pregnancy, you get skyrocketing levels of estradiol and progesterone. And believe it or not, you have skyrocketing levels of stress hormones during pregnancy as well. And then in the menopause, you go through a period of a transition, and that transition will go on and on and on. Sometimes you think it's never going to stop. And then in other people, it's abrupt because they have to go through surgical menopause, or they go through a chemotherapy-induced menopause. We know that women can start having increased risk for both depression and anxiety disorders around the time of puberty. So that's when you start to see the increased risk for women. Before that, males and females had similar levels of depression symptoms and anxiety symptoms. We also know that in the postpartum period, about 10% of women are going to experience a pretty severe postpartum depression. And then in the menopause transition, even if you've never had a major depressive episode in your life, you're 2 to 3 times more likely to have one then than you would have in your premenopausal state. If you've had a previous history of depression, relapse is also quite high. So we know that women are hormonally sensitive, some more than others. Quite frankly, if you study, like I do, the effects of hormones on the central nervous system, I'm shocked that we don't all have difficulties because our brain has to adjust, and we're going to talk a little bit more about that. In puberty, boys obviously have an increase in androgens, and then it kind of stays up till they go through andropause, if they go through it at all. A lot of men can actually die with a relatively high level of androgen levels. And so they go through something very different as far as their hormones across the lifespan. Okay, so what do hormones do? Stop talking about them and tell me what they do. Well, estradiol has an amazing impact on practically every neurochemical in the central nervous system. If you think about serotonin, acetylcholine, norepinephrine, dopamine, glutamate, all of these neurotransmitters have they are in some way affected by estrogen, whether it's their synthesis, metabolism, the number of receptors that are there, how the transporters take up the hormone. I mean, all of these things are really impacted by estrogen. The structure of your nerve cell. And so you're going to hear Frances Jensen talking about neuroplasticity, and I'll show you a slide about what I mean by neuroplasticity. Depending upon where you are in your menstrual cycle, you have more or less of these changes and the neuroplasticity of the central nervous system. And that's going to obviously impact your function, and it's obviously going to impact behavior. Now, sometimes this impact is actually adaptive, and other times it actually isn't adaptive, and people have negative mood symptoms. Progesterone is also really important. And when I say progesterone, I mean natural progesterone. A lot of what people take in their birth control pills and in their hormone therapy is not natural progesterone. Natural progesterone is important because it gets converted to a substance called allopregnanolone, or allo for short. I hope you don't glaze over. I know you just had lunch, but allopregnanolone, you're going to hear me talk about it. Allo is a very potent agonist to a receptor called the GABA system, the GABA-A receptor. Now, why you say, oh God, why is she going to go into, receptors now? Well, how many of you plan tonight to hook up with your friends down at Penn at that little library, and you're going to have a cocktail, or you're going to have a glass of wine, right? I mean, raise your hand. Are you going to that or not? Okay. You are going to imbibe a substance that is modulating your GABA-A receptor, okay? It's just the way it is. So basically, we know that this hormone is incredibly important, not only because it modulates that neurotransmitter, but also because it has some anti-inflammatory effects in the central nervous system. So hormones are incredibly important. They're not all good and they're not all bad. So basically during pregnancy, if the brain wasn't flexible, you'd be asleep the whole pregnancy. Why? Because progesterone is very high during pregnancy. Your placenta is pouring it out, and that's getting converted to allopregnanolone. So allopregnanolone affects that same neurotransmitter system that alcohol does. It also is the same neurotransmitter system that benzodiazepines and barbiturates also affect. So during pregnancy, if the female brain were not incredibly flexible, then we would be asleep the entire pregnancy because we'd have so much allopregnanolone on board. The same thing across the menstrual cycle. We'd have girls falling asleep, in class because in the luteal phase when their hormone levels go up. So the brain has to adjust in order for us to be able to function at our super high level that we all function at on a regular basis. And I promised you that I was going to talk about neuroplasticity. I want to show you here that this is a part of the brain called the dorsolateral prefrontal cortex. What is that part of the brain good for? Well, you organized yourself to get here today, right? You had to make plans. You had to figure out how to organize everything at work, maybe at home, a sick parent. you had to be planful, you had to be goal-oriented, you had to be motivated, you had to be problem-solving. That's a part of the brain. It's why we call it the executive system, okay? These are what we call dendritic spines. When you don't have any estrogen, this is what it looks like. If you've got more estrogen, you've got more of these dendritic spines. These are very important for learning and memory, okay? So cyclic levels of estradiol appear to increase the amount of dendritic spines in this particularly important brain region. And when you can study this in non-human primates, you can actually see that the numbers of these spines correlate with how well the monkey performs a working memory task. So we can actually teach a monkey how to do a working memory task. So to me, this says that cyclic estradiol is actually pretty darn important. But everybody goes, oh my gosh, she's up there. She sounds like she's pro-hormone therapy. Well, I'm not pro or con anything. I am pro understanding the literature so that we can then make informed decisions, okay? So I just want to do a quick summary of the Women's Health Initiative so that we can get past this part and you can guys can listen to the rest of the talk. So we know that these women were 50 to 70 years of age when they were randomized. What were they randomized to? They were not randomized to 17-beta estradiol, which is what I showed you caused those changes in dendritic spines. And they weren't randomized to cyclic estradiol either. They were randomized to conjugated equine estrogen, which is what they took on a daily basis for years. Or if they had a uterus, they were randomized to placebo or the conjugated equine estrogen plus something called MPA. Well, MPA is medroxyprogesterone acetate. What the heck is that? Is that real progesterone? It is a progestin. It is not real progesterone. It's not a natural progesterone. So it does not get converted to allopregnanolone, okay? And that's what you're going to see is going to be important in a minute. The study was stopped prematurely, not only because the expected degree of reduction in their primary endpoint, which was coronary heart disease, in this combination group, the CEE plus the MPA group, and that the benefits did not outweigh the risks. So basically, they did not think that it made sense to ask women to continue to do this particular arm of the study because they weren't seeing enough of a decline in the coronary heart disease and again had increased risk. The CEE alone part of the study continued for 2 more years. And actually, there was lower risk for coronary heart disease in that group versus the placebo, as well as lower risk of invasive breast cancer. Now, everybody says, oh my gosh, I always thought that the Women's Health Initiative was stopped because of the increased risk in breast cancer. That's not actually the interpretation. The interpretation is that when you design a study, you have to have primary endpoints. And if you aren't going to meet your primary endpoint and there are potential risks of doing what you're doing, then you have to then really reconsider stopping the study. So what do we know now? So circa 2017, they've actually just published data now after 18 years of follow-up of this population. And the group that just got the conjugated equine estrogen alone, they did have lower risk of coronary heart disease, and they had lower risk of invasive breast cancer. Using a global index of risk, so if you combine all the benefits and all the risk, and you do a calculation, the global index of risk for basically if you said per 10,000 women annually, there were 19 fewer women ages 50 to 59 and who wound up here having this high global index of risk, and 51 additional events for women 70 to 79. So again, what is this telling us? It's telling us age is important, okay? And then again, the study did continue a little longer. In the combination, we do see that in laboratory studies, medroxyprogesterone acetate actually negates the protective effects of estradiol in the brain. So here we were giving people estrogen and hoping it was going to have a good benefit on the central nervous system, if you're a psychiatrist, heart, if you're a cardiologist. But the bottom line is we were also giving them medroxyprogesterone acetate. So it's amazing that we didn't do more harm than good. Using a global index of risk, there were definitely more events in this combination group. So there were 12 additional events, but again, per 10,000 women. And then 38 additional events in the older age group. But the bottom line is that there were no increases in all-cause mortality, cardiovascular disease events, or cancer-related mortality. And that's in either group. And that's with 18-year follow-up. And those data have just been released. So it's really quite remarkable. In 2002, we all took everybody off of hormone therapy because we thought it was the most dangerous thing we could do. Oh my gosh. And then now we're still trying to figure out, what did we really learn? And we're learning as we go. And sometimes it makes the public a little less confident in what we're telling them because we seem to be going back and forth. And what I want to really encourage you to think about is that we learn as we go, and sometimes you have to study people over longer periods of time in order to be able to come up with this final statement. So the take-home message on this is one size does not fit all. Age at which these women were randomized had an impact on whether they had good effects or bad effects. Your baseline health. Did you have coronary heart disease? Did you have brain disease when you first started? Because they have done brain imaging in this population. Again, it appeared that the mix of estrogen and the medroxyprogesterone acetate had a negative effect on your brain if you already showed brain disease at baseline. So again, there's something we call the healthy cell model, that estrogen seems to be more beneficial if your cells are healthy. The type of hormone, is it MPA? Is it natural progesterone? Are you taking it orally? Are you taking it through the skin, transdermally or vaginally? Those are other questions that people are asking. But we have evidence now that these women did not have an increased risk in mortality. And I think that that's really an important finding. So who is my typical patient? I'm going to get off of the Women's Health Initiative at the moment. My typical patient is somebody who comes in. Liz is a 51-year-old married executive. She has 2 teenage daughters. Since her menstrual cycles have become less regular, she has noted problems with word finding, motivating herself to get her work done, focusing at work, just kind of overall feeling a lack of organization. And she says to me, she goes, I'm just not on top of things as much as I used to be. So she's concerned. She's having night sweats. It's interfering with her sleep. And interestingly enough, during the day, she knows when she's going to have a hot flash because she starts to feel anxious prior to the hot flash. And that's really frustrating to her. Her libido is non-existent. That's really frustrating to her husband. Okay, Liz says she's not depressed, but she knows that she's not herself. Her father died of heart disease when he was 60, and her mother has early signs of dementia at 79. She's terrified of hormone therapy because her best friend had breast cancer. So the question is what do I do for her? Who is this person? Is every menopausal woman like this? Well, no, the answer is not. Not every menopausal woman has hot flashes and night sweats. The majority do, but not all. Not everybody has that anxiety before their hot flash, but that is also becoming more and more commonly discussed. Not everybody has any symptoms. They go through menopause very abruptly and they're fine. Why is this happening to her versus the person who says, I had no symptoms, I went through it just fine? Why is that happening to her? Why is it going on for 8 years? And what are we going to do about it? Those are the questions that I ask myself every time I meet a patient. And that's the kind of questions that instill in my mind this notion that, again, creation of new knowledge, because I want to know why, because if I know why, I might be able to intervene sooner. And I also want to know, is this a person who, because this is actually not the most severe case that I see. I mean, I see a lot of people who have it a lot worse than this, but this is typical. So cognitive aging affects us all. So Liz is not abnormal. I'm sure that her husband would also say, oh, Liz, get over this because I've also got some word finding problems. So is menopause special? And if it is special, what is the hormonal contribution? Is it the ovarian hormones? Is it the stress hormones? Is it the fact that in menopause you're at higher risk of depression symptoms? Is it that anxiety that she was experiencing? We have data to suggest that it's the inflammatory effects that happen with loss of estradiol, that when you have a decrease in estradiol, that your inflammation and markers of inflammation can increase. So is the person who's having greater difficulty, is that because they're having a greater increase in inflammation? We don't know. And what about this hormonal fluctuation can unmask this risk for people who've never had any cognitive or mood problems before? So the evidence is that menopause is indeed special. Longer reproductive periods is associated with better cognitive performance with aging. So having a longer period of time where you're fluctuating and having menstrual cycles seems to be helpful. Premature menopause is associated with cognitive decline, but it's also associated with increased risk of dementia if women go through menopause before the age of 40. No, 40. And so the bottom line is that we need to be talking to our ladies who are undergoing a premature menopause. Similar is true for cardiovascular disease and cardiovascular mortality and all-cause mortality for women who go through menopause before the age of 45 who don't use hormone therapy. Because basically the average age of menopause in the United States is 52. So if you are in this study, and this is the Mayo Clinic, very large longitudinal study, showing that, again, in this younger population, estradiol seems to be very important. So what about stress? Full-time working mother, you think she's stressed? Teenage daughters. You're not, you guys are out of that now. You think she's stressed? Mother with dementia. She's probably a caregiver too. So she's a sandwich generation. And she has the biological stressors of having these hormonal fluctuations that are affecting her internal organs, affecting her sleep, and affecting her brain. So yes, this woman has stress. And unfortunately, stress is an important part of life. Stress is what gets you to get up and do what you need to do because you need to be able to attend to something. So stress is actually helpful in the long haul if it's not prolonged and if it doesn't feel like it's out of your control. But unfortunately, most of what we experience, we find that these are chronic daily stressors and they can also really wear you down. So does sex matter here? Well, come on. What's the answer to this question? Yes. So we study women and men across the reproductive lifespan, and from pregnancy of one individual, looking at their offspring, following those offspring, and then we also follow people through multiple generations. We're very interested in the impact of stress. And when I say stress, I'm also not just talking about daily hassles. I'm talking about adverse childhood experiences that could be quite dramatic. But also stress in pregnancy could be the daily hassles. And again, it makes a difference whether you're in control of those daily hassles, you feel like you've got a handle on them, versus they are overwhelming you. And believe it or not, sex and gender do impact either the stressors you're exposed to. So females are more often exposed to sexual violence, whereas males would be more often exposed to combat violence or motor vehicle accidents. So again, gender is important. Sex is also important because the biology of our reproductive hormones, so our estrogen levels, our progesterone levels, our allopregnanolone levels, impact how we respond to stressors in our day-to-day life. How do we quantify early life stress in our work? We use the Adverse Childhood Experiences Scale. And basically, we ask 3 questions about abuse, 2 questions about neglect, separation, divorce, and then 4 questions about the household that they grew up in. And this has been shown that the more ACEs you have, the more at risk you are for cardiovascular disease, metabolic disorder, autoimmune diseases, migraines, substance abuse, suicide, psychosis. I mean, I could list a whole number of disorders. And we consider anybody who has 2 or more as being in our high ACE group. And this is before the age of 18. And basically what we've done is worked with Ellen Freeman and a biostatistician, Mary Samuel, to look at the impact of early life stress in childhood for women as they go through menopause and whether it contributes to depression. And what we found is not only does having 2 or more adversities in the post-pubertal window, so after you started getting your menstrual cycles, That increased your lifetime history of depression, which is not really new news. But what was new news is that it increased the risk that you would have onset of depression in the menopause. So those women who only have the episodes in the menopause, suggesting that even though they went through their whole life, their whole reproductive life, having experienced these childhood adversities, it wasn't until they went through the hormonal fluctuations of menopause that they unmasked this vulnerability for depression. So again, it emphasizes the importance of one's life events in relationship to their hormonal changes. And these are data that were funded and study funded by the Office of Research in Women's Health and the NIMH. We've also looked at cognition, because most people are very worried. I say, oh, okay, I don't worry so much about depression. I'll take an antidepressant and I'll be fine. It's very treatable. But God only knows. I mean, we don't know what to do about dementia, and I really don't want to get that. And even if you're not worried about getting dementia, you don't want to have any decline in your processing speed or your capacity to organize or juggle things, because you're busy. You're at the top of your game professionally. I mean, you got a lot going on. This is not the time to start having cognitive problems, right? Correct me if I'm wrong. Am I right? Yes. Okay, thank you. So we studied cognition in the same menopausal women and said, okay, what contributes? What part of early life stress? And we found again that having stress, 2 or more ACEs, before the age of 18, increased your, or actually increased your cognitive aging. I will put it that way. So we saw that was not true, though, unless we looked at markers of inflammation. So again, we had to take a biological variable and pull it in to see whether, okay, we weren't really seeing the effect of stress per se until we looked at inflammation. So basically, we saw that if you had early life stress plus an increase in these inflammatory cytokines, that your processing speed looked worse as you went through the menopause transition, and your verbal recall was worse. So this is an example of how early life stress interacts with the biology that you're experiencing now, namely inflammation, and the hormonal changes you're experiencing now. And again, these are funded by the NIH. So we can't get rid of stress that's happened to us in the past, right? What's done is done. I see plenty of women that I wish I could go back and erase their childhood, or erase the terrible divorce that they had to go through, or erase having lost a child. I mean, horrible things are happening to people, and we can't go back and do that. What we can do, and we know, is that stress is going to happen in the future as well. That's predictable. So what are we going to do in order to be on that road or on that path to health and happiness, which is the theme of your fall retreat? And you're going to make all the efforts you can. And it's never too old, you're never too old, and you're never too young. Do whatever you can to decrease inflammation. You want to have a diet that really is not pro-inflammatory. You want to exercise in a way to also decrease. I'm not saying you have to be out there running a marathon. You know, moderate exercise is enough. And you're going to hear about, Michael Bain's going to talk about meditation. I took his course. Any of you that haven't taken his course, that live in the area, you should be taking his course. Meditation is really important. It helps you to be in the here and now instead of fretting about yesterday and tomorrow, okay? And it has been shown in the best kind of studies that we can do that meditation is helpful with respect to inflammation. Because if you've had early life stress, you can't go back and change it, but you can change factors in your life now. I also think that if you've had early life stress and you haven't ever dealt with it, there are better psychotherapies now than we had in the past. The psychotherapies we have now, a lot of them are trauma-focused, stress-focused, and you can really learn some amazing skills in addressing some of your childhood and maybe young adulthood issues by going to somebody who's well-trained. And there are people here that do this kind of trauma-oriented therapy and study it. And it is very, very effective. I would say consider hormone therapy if you're a young woman who's very healthy and you've had a lot of symptoms. It is certainly something to consider. Don't wipe it off as something dangerous to not be considered, because we're finding out more and more data that it is completely within the realm of our armamentarium as to how to help you feel better. And I would say consider participating in research. We're now funded by the National Cancer Institute to study women who have undergone a premature menopause due to being BRCA1 or 2 gene mutation carriers. And if you know anybody that fits, that's having some cognitive issues, particularly with that organization, executive functioning like Liz, then send them our way. Okay. Do participate in group activities with female friends. Basically, that's important. It's what you're doing right now, whether it's coffee, exercise, having a glass of wine. Data show that women find other women, by and large, soothing. That when we're under stressful situations, that we prefer to be with other females because of the soothing quality. And that might have something to do with that wonderful hormone oxytocin. So be with your friends, enjoy what you're doing here today, because this is where you're going to get your juju. You're going to get your energy. You're going to get that oxytocin energy that's going to be able to take you to deal with all the stress, or at least for the first 24 hours of dealing with the stress once you get back home. It's not a miracle, but do find time to participate in activities that give you pleasure. Mo, when you are on those drums, aren't you just rocking and having a great time? I mean, it's the best. You probably could deal with so many student, issues if you have time playing.
Especially if you're singing along.
No dancing. All right. Because even sex, I'm taking it full circle. If sex is what you enjoy, then do it, okay? You get oxytocin when you have an orgasm, but you also get a shot of dopamine when you do things that you find pleasurable. So when Mo is on the drums, it's like no other drug that you can find out there. You're having a great time. Your dopamine is surging. She's out there with her band members doing something together. Oxytocin is flowing. Again, these are basic things. This is not rocket science. And this is stuff that we can do. So as a citizen science, you guys participate in research. We need precision medicine. We need personalized medicine. We need a wide range of people that are involved in research. We also need to tell people and support research that considers sex as a biological variable. And for women, the hormonal state and reproductive state is super important. It gives us the best scientific rigor. Because you may not know this, but of the 8 or 9 drugs that the FDA took off the market in the past decade, they mainly took them off the market because women were having greater adverse events related to those drugs than men. And again, we should have known that before the drugs got out on the market. It makes our data more reproducible when we consider sex as a biological variable, and we will decrease these adverse outcomes. And again, we're going to be promoting treatments that work best for women as well as men. So be a citizen scientist, and that is the end. I think I have a few minutes for questions. Bye, Mo. See you later. Any questions? Well, I do have cards. Yes. All right. Oh, yeah. And I'm so sorry you had a poll in the way. So.
Where does coffee fit in as a dietary?
Oh, yes. And sugar. The bottom line is that sugar and fats do increase the likelihood that you're going to have a greater inflammatory response. So like if you eat a very fatty diet and then you stress somebody and you measure these like chemicals that I measured in these women, then they will have higher levels because they ate the fatty diet. So if you're really wanting that cheeseburger, just make sure you're going to go home and chill out and that nothing bad is going to happen, that you're not going to feel stressed. But having it for lunch when you have to have a stressful afternoon is not a good idea, okay? So I'm not saying never eat the fatty food. I'm just saying that you got to know what's going to happen. And so Sugar's also, unfortunately, a bad actor when it comes to increasing inflammation. Coffee, I don't know. I just say, I'm one of those people that says that if you do most things in moderation, it's okay. So, well, oh, well, I don't know. I'll give you my card. Back over there was a question. Oh,
Coffee affects your cortisol. So
good.
you want to do it in moderation because if your cortisol's off the, if your cortisol's off the hook, then the stress hormone, then you're not helping your hormones.
Right.
And I would say with a fatty meal, if it's a healthy fatty meal like avocados and butter,
Oh, that is true.
that's okay.
Yes.
Cheeseburger, yes.
Yeah, yeah. I appreciate that. She's absolutely right. I eat lots of avocado. Yes. 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 The data have not been very helpful to suggest that you can dramatically alter your serotonin levels by diet alone. I would say that if anybody's having sleep difficulties, that they really do see somebody who knows sleep medicine, because actually there's a fair amount of restless leg syndrome as well as sleep apnea, even in a menopausal aged woman who's doesn't have all the other obvious risk factors. And so I would say anybody who's had a lot of problems sleeping, just see somebody for an evaluation, because it could be that there's anxiety, it could be that there's depression, it could also be that you have restless legs, or some other kind of diagnosable sleep problem. With that said, there have been some studies that have looked at the serotonin reuptake inhibitor type antidepressants in menopausal, perimenopausal women with sleep difficulties. And those individuals did have some depression. So it's hard to know if their sleep got better because the drug actually helped the depression, or if their sleep got sort of better independently. But look, I think a lot of things are on a continuum. We know that sleep gets disrupted with most major psychiatric problems. We know that. We know it gets disrupted with these hormonal changes. So I think that if you're having great difficulty, to try different things for a period of time, but keep going back and saying, is this working or is this not working? Because again, even milder levels of depression could present with more sleep difficulties. That might just be one of your symptoms, that and sort of mild depression. And because you've got great coping skills, and all of you do, that you're able to kind of charge through. That's what we see a lot, is that people, because their capacity to function is so high, that they wind up tolerating a fair amount of negative mood because they can kind of just charge through it. And that's why I think it's better just to get an evaluation so that you have somebody else kind of looking at your situation. So, yes, I think she had her hand up, and then the lady next to her. Yes. I'll say the question again.
I question the validity of my voice. Research has suggested that women are twice as likely as men now to get Alzheimer's disease and related dementias.
Yes.
And there's a new study that is suggesting, it's actually on the Today Show with Maria Shriver this week, about hormone therapy, and that women maybe should have had it to ward off dementia. I see the look on your face. I'm wondering what your take on that is, and also why you think women are twice as likely.
Well, look, it's a very difficult question to some degree. I think that the female brain, if we want to say that if you're an XX chromosome person, you probably were sexed in utero with the brain exposure to certain levels of hormones. And the bottom line is that a lot of what we experience later in life actually started in utero. And so that is really the first environment. So there's a whole host of sort of prenatal programming, research, and different factors looking at mom's stress during pregnancy. Did she have a viral infection during pregnancy? What was her nutrition like during pregnancy? Because obviously you would want this first environment to prepare the fetus to be born out into the world and be successful. And unfortunately, that sometimes it is successful and it is adaptive change, and other times it's not. Do I think that prenatal programming is why women experience dementia at a greater rate? Probably not. It's probably a piece. but it's probably because their brains have been exposed to estrogen across their lifespan, and perhaps the female brain needs it more than the male brain. Now, the males actually do have estrogen in their brain. They just don't have as much because you retain the capacity as a man to be able to aromatize testosterone that comes into the central nervous system. You aromatize it to estrogen. So people have actually also wondered if we should start giving men some kind of estrogen because we know as they age that that aromatization process doesn't happen as well. So I think that estrogen is involved. I think the preclinical data suggests that cyclic estradiol can be helpful for neuronal structure and architecture and the making of connections between nerve cells. Those little dendritic spines are very important for making connections. We need them for learning and memory. But in this one animal study, and I tell you, it is just one monkey study. It needs to be redone, and I've been trying to figure out how to do this study in humans. It's not an easy thing to do in humans. But basically, they showed that if you took estrogen every single day at the same level, that you didn't get those fluctuations in the dendritic spines, and that they just kind of whittled away. So we may not be giving hormone therapy in the best way. And I know a lot of people are really trying to figure this out, but NIH is really not that interested in supporting research focused on trying to tease out, is this enough hormone or is this too much hormone? Because that really requires precision. So we need to use our brain imaging techniques, some of which I do, to be able to look and say, okay, in a group of women, we gave them consistent levels of estrogen. How did they perform on these tasks? What changed in their neurochemistry? And women who used it cyclically, what happened to them? And then let's add the progesterone in there, because that has to be added in if you've got a uterus. So there are a lot of questions that we've really got to study in humans. Unfortunately, it's just not, we just don't have the resources to do it at this point. Yes, ma'am. Oh, you had a question. I'm sorry, then you. Okay.
There's a lot of negative stuff out there in the last few years about statins and women and,
Statins and women.
about statins in women.
Mm-hmm.
And a question that I've come across recently is whether high cholesterol without inflammation even is a problem for women. And I'm just wondering what you think about that.
Well, it's a little outside my ballpark because I don't study cardiovascular health by and large. But I mean, the bottom line is that my understanding is that higher cholesterol, higher triglycerides does increase the risk of development of coronary artery plaques and cerebrovascular plaques. Somebody else I know is doing cardiology here. No. That's not my area. It's not. So I wouldn't think that it would be great, but I can't really comment any more educatedly on that. Sorry. All right, one more question. I think this lady had. Oh, and no, two. We got 1, 2. And I think that's all we're going to be able to do. But I'll stay around. Yes. Yes, they do.
And what effect that has on the mix. And I can say from experience it has a lot.
Yes, okay. So testosterone. Well, testosterone is very important, but it's more important in some women than others. All the data about trying to increase women's libido with use of exogenous testosterone in the placebo-controlled design, again, the standard we use is that placebo-controlled design, it seemed like in the whole group that testosterone was not better than placebo at increasing libido, sexual functioning, and enjoyment. It might have been, though, in a subgroup who had a very strong sex drive their entire life, and they noticed a major drop. And to me, if you've had a really strong sex drive your whole life, and maybe you were sort of more responsive to androgens throughout your life course, then it makes sense that during the menopause that you might benefit more than 10 other women whose sexual interest has kind of dwindled over the course of the decades. Again, we also see the sexual functioning is very difficult to assess what aspect of sexual functioning, because there's a lot of mental aspects of sexual functioning, as well as the physical aspects of lubrication and arousal, climaxing, and those kinds of things. So overall, I only use testosterone in people who go through early menopause and are having sexual issues, or they're somebody who basically says, look, I've always liked to have sex at least as much, if not more than my partner, and I really notice that this is a major decline. And then I would say, okay, fine, let's try some androgen. But I do tell them about the placebo-controlled studies because, that's what we have is, in our armamentarium. All right, one last question.
When you were talking about the women that had gone into premenopausal, is there, I'm going to call them the at-risk category, when they were chemically induced into premenopausal, early menopausal, is that a difference in results for the cognitive?
Yes. Basically, whether it's chemotherapy induced or whether it was oophorectomy, it's not clear that there's a huge difference. People have talked about chemo brain and said, that again, people go through sort of a protracted period of time after chemotherapy feeling foggy. And a lot of times if you've had breast cancer, you've had to also use aromatase inhibitors and other medications as adjuvants that can also have an impact. Again, I don't see that in everybody. The people who come to me are the people being referred by their oncologist because they are having difficulty. So I'm trying to figure out why are they having a difficulty and this other person isn't, and what can I do about it? And so that's what the NCI is funding us to do. So we've basically you can go through a chemotherapy-induced menopause and be in that project, but you have to still have your ovaries removed because we are trying to limit the number of possibilities of how, because if you still have your ovaries, you're still secreting some hormones, and so people have really questioned what the postmenopause ovary is doing. And for some people, it seems to make a difference whether they have their ovaries or not. In the longitudinal study from the Mayo Clinic, I don't think that they took that particular thing into consideration. Okay? All right, so I will stay around, and I'm happy to answer any questions you have.
Thank you so much. That was such an interesting lecture. I enjoyed it very much. So thank you, and I'm sure thank you for sticking around.
Thank you. Oh, it's very sweet. Oh. Yes, that's great. Thank you. Oh, no, thank you. That's great. I didn't even know they made these.
We're now going to proceed to our committee meetings, and there'll be people to direct you to which room you're in. And please, I'm really asking everybody to make sure they submit their committee minutes to Terry so we have them for the meeting tomorrow. So thank you, and onward to the committees.